Hi everybody, we're going to pick back up in your course pack on page 39 with the cardiac conduction system. It is alternately called the cardiac cycle, and toward the end of this video we will talk about the EKG or electrocardiogram. This is a great time to go back and review blood flow. The blood flow information is found in your course pack on page 38. There's also a great link to a YouTube video down at the bottom of this screen. You may want to copy and paste that in and take a look at it. This particular picture labels the steps of blood flow from 1 to, 15. I would also encourage you not to get stuck with just using the SVC and IVC and coronary sinus as your starting point, but also to pick any point along the pathway and use that as your starting point. That way you don't get so entirely comfortable relying on only knowing one flow path through the heart. So we're going to talk now about the cardiac conduction system and the cardiac cycle. First, I just want to remind you that cardiac muscle tissue is built for a special type of contraction here. This kind of contraction is basically contractions that the heart can do on its own without the need for external stimulation. That is very unusual. No other muscle tissue works in that way. So in looking at the cardiac conduction system, we do have an intrinsic or a built-in nervous system, and that nervous tissue is within the heart muscle, and it helps to control the heart rate. The fastest piece of intrinsic nervous tissue is the one that sets the pace of the heart rate. So there are multiple pieces of nervous tissue scattered throughout the muscle tissue of the heart. It is the one with the fastest pace that is called the pacemaker. And so for most people, the pacemaker is in the right atrium in a node of nervous tissue called the sinoatrial node, or SA node for short. There is a number 2 in charge, and that comes from the atrioventricular node, or AV node, and it serves as a secondary pacemaker. So notice that the pacemaker in the AV space is about 40 to 60 beats per minute. That's much slower than the normal pace set by our pacemaker in the SA node, which is 75 beats per minute. Okay, so if our pacemaker in the right atrium is not in charge, what do you think happens to our overall heart rate? It slows down because the number 2 in charge, the AV node, becomes the one that then sets the pace at 40 to 60 beats per minute. On your worksheet, we have some information there to fill in about tachycardia and bradycardia. The normal heart rate range is from around 60 to 100 beats per minute, although 75 is considered the average normal heart rate. If you're dropping below 60, then we have a condition called bradycardia. So you'll want to fill in that blank. It is a heart rate slower than 60 beats per minute, while tachycardia is an abnormally fast heart rate found above 100 beats per minute. All right. Down near the bottom of your page, bottom of 39, you'll notice some information on the autonomic nervous system, providing external control of the heart rate. We know that sympathetic and parasympathetic nervous systems are branches of the autonomic nervous system, and these two can either speed up the heart rate using epinephrine and norepinephrine, or slow it down through the actions of the vagus nerve and acetylcholine. You may recall acetylcholine, or ACH, from muscle conversation back in Bio 210. I'm going to save our conversation for autonomic nervous system until we've had an opportunity to walk through the intrinsic nervous system first. All right, so taking a look at this picture, which part is your pacemaker? Your SA node should be your pacemaker. And what is the normal rate, heart rate, that the SA node sets the pace? That's 75 beats per minute. Okay, what is your number 2 in charge? Number 2 in charge is your AV node, and left to its own devices, it would set the pace much slower at around 40 to 60 beats per minute. Okay, so where is the AV node located? Well, it's kind of down here near the interventricular septum, compared to the SA node, which sits high up here in the top part of the right atrium. So let's talk about this particular pathway called the cardiac conduction system. This conduction system is based on built-in nervous tissue, part of an intrinsic conduction system. This nervous tissue promotes the contraction of the atria together as a unit, a pause, and then the contraction of the ventricles together as a unit. Let's start with the firing of the SA node. When it sends an impulse, the impulse travels across the walls of the right atrium, you can see here, and into the walls of the left atrium. As a response, the atria contract first. So SA node fires, atria contract first. The nerve impulse will then reach the AV node. There's a pause here though, because we don't want the AV node to fire immediately at the same time as the SA node. Why? We want the ventricles to fill up with an adequate amount of blood. So there's a pause here. The AV node then sends a message down a bundle called the bundle of His. That sometimes is called the AV bundle or AV junction or atrioventricular junction. You'll notice it sits right here at the interventricular septum, and then it immediately splits into two branches, a left bundle branch and a right bundle branch. These bundle branches are found in the interventricular septum. The nerve impulse then travels up the walls of the two ventricles, and they terminate in these fibers that are called Purkinje fibers. So let's hit this from the top again. SA node fires first. The impulse travels to the atria. They contract. The AV node now receives a message. There's a brief pause, allowing the ventricles time to fill with blood. And then the message is sent down the bundle of His, bundle branches, Purkinje fibers, and now the ventricles contract. Okay, so when the AV node fires, it travels down the bundle of His, down the branches, to the Purkinje fibers, and then of course the ventricles contract. All of this takes 0.8 seconds. And so that is the length of the cardiac cycle because that ensures a pace of about 75 beats per minute. Let's take a look at this image. We see again that the SA node fires the impulse first. It is the pacemaker because it has the fastest firing node of nervous tissue. The SA node causes what two chambers to contract first? Atria. The nerve impulse next reaches our secondary node. It is called what? The AV node. When the AV node fires, the nerve impulse travels to a bundle here called the bundle of His or atrioventricular bundle. It then splits into these branches traveling down the left and the right sides of the interventricular septum. And then of course we travel up the walls of these ventricles terminating in fibers called Purkinje fibers. Those Purkinje fibers then release neurotransmitter, acetylcholine, onto the walls of those muscle cells, and again the ventricles now contract. So the SA node promotes the contraction of the atria, while the AV node controls the contraction of the ventricles. This is a relay mechanism. The whole cycle that produces one heartbeat is approximately 0.8 seconds. Okay, that is the length of one cardiac cycle, and that equals our pace, which is 75 beats per minute. All right, so here we go again. SA node fires first, AV node fires second. You'll notice the SA node promotes the contraction of the atria, while the AV node promotes the contraction of the ventricles. All right, so that should take you through the majority of page 39. We will talk more about the autonomic nervous system's control as we reach another part of this chapter. For now, let me take you on over to the electrocardiogram information on page 40 and 41. First, I need to share some background information you should have learned in Bio 210. Way back in Bio 210, you probably learned about membrane potential when discussing muscles and nerves. We know that when muscles and nerves are sitting at rest, they carry an overall negative charge on the inside and an overall positive charge on the outside of the membrane. One way to simplify this is just by looking at how many ions we have in each relative location. Because we have more ions on the outside of our cell and less ions on the inside of our cell, we can say that there's a relative imbalance here. So the place where you have more of those ions, you're going to have a positive charge. And wherever you have less, you're going to carry a negative charge. So if you take a look, what we have outside the cell is mostly sodiums, a few potassium ions, while what we have inside is very few sodiums and a few potassium ions. So you're looking at a polarized membrane here where you've got an imbalance of more sodiums outside, less potassiums on the inside. So membranes and cells stay at rest when they have this setup, what we call a polarized cell. In order to change the polarity of the cell, we have to change the balance of sodium and potassiums in their locations. In order to depolarize, we open up a sodium channel, sodiums rush in. Now, the majority of ions are on the inside. Well, we know that the majority of the ions is where the positive charge is had. So what is the charge inside the cell? It's positive. And now there's less ions outside the cell. Less means there's a negative charge out there. So we know that the movement of sodium through this sodium channel creates an electrical current, changing the positive charge to the inside location now, making the outside relatively negative by comparison. In order to place a cell back in resting state, we undergo repolarization, and in this place we see the sodium ions no longer can enter into the cell. Now, potassium ions leak out through potassium channels. So when potassium exits the cell, we are now putting the majority of the ions back outside, placing the positive charge on the exterior of the cell and restoring the negative charge on the interior of the cell. That's because we now have the majority of the ions located outside, and very few of them located here on the inside. Okay, so it's the movement of these ions that creates an electrical current. It is the movement of these ions that show up as waves on our electrocardiogram. So let's talk about the electrocardiogram for a moment. The EKG or ECG is a measure of electrical activity in the heart. What you're looking at here is called a normal sinus rhythm. This is picture perfect. This is how you would ideally like to see an electrocardiogram work. But because an EKG can pick up any electrical activity in the body, simply moving while an EKG is being performed can disrupt the signals and make it look like something is going on that is not. So that's one reason it's important to stay really still during an EKG, since other electrical activity for muscles, like skeletal muscles, can be picked up. Hey, if you can keep the letters of the alphabet in order, you've got part of your game covered here. P, Q, R, S, T, and there's even a U wave. That's the letters of the EKG that we're going to be taking a look at. Just a couple of things to note here about the EKG. Positive upward spikes, ones that appear like this, are ones that are coming toward the electrodes placed around the body. If you happen to see negative spikes like this, that means the nerve impulse is going away from the electrodes. I want to emphasize here that the up and downward waves does not indicate sodiums or potassiums moving in any particular direction. It only means that there is a nerve impulse traveling either toward electrodes or away from electrodes. So if we have an EKG that looks like it's upside down and reversed from what it should be, then that might indicate that the electrodes are placed in the wrong position on the body. We also look for an isoelectric line. It's a baseline. It's basically 0 millivolts, and it will run through the middle of your EKG. When we see upward spikes, they are going toward the electrodes, and then when we see downward spikes, they're going away from those electrodes. Most of our EKGs nowadays are digital, but if they are printed out on paper, do look for that 0 millivolt isoelectric baseline. EKG paper is the way we used to do this. We didn't have digital processes back, years ago. So we still use this grid mark system here to guide us in looking at what's happening on an EKG. So to start off with, let me draw a large square here. That large square is made up of 25 small squares. That large square also passes through the machine at 0.2 seconds. So the distance here that this passes through the machine is 0.2 seconds. Take a look at the bottom down here. If this is 0 right there, this one box is 0.2. The next box, add it together, that's 0.4. Now we've got 0.6, 0.8, and right here we've now passed 1 second of time. Okay, that's because each box is 0.2 seconds. Now I'd like to take you through and walk you through the P, Q, R, S, T, and U waves. All right, and just of course a reminder there that 0 isoelectric line, 0 millivolts, waves above go toward electrodes and waves below go away from electrodes. All right, so let's talk about that P wave first. In order for the P wave to occur, the SA node must have fired at some point before that P wave. So I'm just going to make a note here on my picture that SA node fired an impulse. In order for that SA node to fire an impulse, we have to assume that we're beginning the cardiac cycle, and in response, the nerve impulse travels to the walls of the atria, and they then contract. Now, you know from Bio 210 that in order for muscles to contract, they first must depolarize. So you're not actually seeing any muscle contractions on this EKG. All you're seeing are waves for depolarization and waves for repolarization. Okay, so the P wave is equal to atrial depolarization. And what does that mean is getting ready to happen? They're getting ready to contract. Okay, so let me reemphasize this point. There are no waves here for contractions. The only waves that are showing up are those for depolarizations and repolarizations. So when the SA node fires, that P wave right there represents the atria depolarization event. That means sodium's flood in, they're getting ready to contract. Where do they contract? At some point after the P wave is over, and they repolarize behind that QRS wave. So we actually never see anything else for the atria. We assume the contraction event and the repolarization event is all hidden behind the massiveness of that QRS wave. Okay, so this just is a good review for us. P wave represents atrial depolarization. The atria are preparing to contract. All that wave represents to us is sodium rushing into the cells of the atria, preparing to depolarize and contract those muscles. So prior to the P wave, we assume the SA node has fired. The P wave is just a representation of the sodium ions flooding into those muscle cells in the atria. Let's now talk about the QRS complex or wave. That's this portion here. It's rather large because we're looking at a greater depolarization event for the ventricles. Why? It's because those ventricles have more muscle tissue. Remember, they are larger and thicker in myocardium than are the atria. So let's go back and review. Right here, the SA node fired an impulse. That means the P wave was atrial depolarization. The atria contracted and relaxed behind that QRS wave. But we know in order for those ventricles to contract next, we must have another node fire, and that is the AV node. So right between the P wave and the Q wave, we're going to put a note that that's where the AV node will fire an impulse. In response, the ventricles will prepare to contract, and we call that depolarization. All right, so again, we're not looking at a wave of contraction. There are no waves here that represent contractions or relaxations. We only represent waves using repolarizations and depolarization events. So the QRS wave says ventricles are preparing to contract, sodium is flooding in, those muscle cells are preparing in order to contract, which occurs at some point between S and T wave. So I'll just make a little note there that ventricles contract after S before T. All right, just recall that the QRS wave is so large because we have more muscle tissue in those ventricles, and that QRS wave also hides atrial contraction and repolarization. There's nothing to see. It's all happening behind the timing for ventricular depolarization. All right, so let's relabel this. SA node fires before the P wave. Where does the AV node fire? Before the QRS wave. Where does the atria contract? Where do they repolarize? Hidden behind the QRS wave. Where do ventricles depolarize? That too is the QRS wave. Ventricles contract somewhere between S and T, but T wave specifically here is for ventricular repolarization. So what happens during repolarization? That is the time when potassium ions leave and exit that cell, helping it to restore its resting state or negative interior charge. We're not going to focus a whole lot on that U wave, but I'll go ahead and tell you what it is since it's in the picture. The U wave is papillary muscle repolarization. You may recall those papillary muscles are anchoring the chordae tendineae. Those are the cords that anchor the AV valves. Now, if you repolarize them, that means that the contraction event is over and that they're resetting back for another go-around. Keep in mind, what you're looking at here for the EKG is a cardiac cycle. So what is the length of time that it takes for an entire event to happen? Once again, it is 0.8 seconds for the entire cardiac cycle to occur. That is from the start of the SA node until the muscles are reset and ready to fire again. All right, so T wave is the last major wave that we'll talk about. You don't need to learn the U wave. I just wanted to share what it was since it's on the picture. T wave represents ventricular repolarization. That means we're restoring the resting potential and preparing for those muscle cells to relax. Then we can start the entire cardiac cycle once again. If you would like to look at EKGs and some disorders from EKGs, great website here for the Nobel Prize. I encourage you to take a look at it. You can even play a game with these EKGs and diagnose disorders. I'd just like to take a moment to run you through some potentially problematic EKGs and some that are not so terrible. They're found on page 41 of your course pack. This one is probably the easiest one to spot because it's called asystole. That means there is no systolic contractions. This is what we call flatline. There's no cardiac electrical activity. In this case, if epinephrine or heart massage is used, it is used as a way to help jumpstart the contraction events in the heart and hopefully to restore that SA node as the one in control. If paddles are used here, they are used with caution because unfortunately this can lead to clinical death. Within 5 minutes, the brain is probably deprived of adequate oxygen to not be functional. Within 15 minutes, that is clinical death. This particular disorder here is called third-degree heart block. Now that we have a couple of QRS waves to look at, I can mention to you how to count the length of a heart cycle. We don't actually start from P wave to P wave. Instead, we count from peak of R wave to the next peak of the R wave. So right here is the peak of an R wave. Over here is another peak of an R wave. In order to count the length of the cardiac cycle, I have to estimate that each box is 0.2 seconds. So bear with me, we're going to count. That R wave here is my 0 time, so 0.2, 0.4, 0.6, 0.8, there's 1 second. 0.2, 0.4, 0.6, 0.8, there's 2 seconds. 0.2, 0.4, 0.6, 0.8, there's 3 seconds. 0.2, 0.4, 0.6, 0.8, there's 4 seconds. Wow. 0.2, 0.4, 0.6, 0.8, there is 5 seconds between those R wave peaks. That tells me my cardiac cycle is 5 seconds long. How long is it supposed to be? It's supposed to be 0.8 seconds. So what starts to happen in this time period? Well, unfortunately, blood can begin to clot, and we can throw clots if the heart is able to pump out this blood. So here's the problem. The SA node impulse does not travel to the ventricles. The impulse may be blocked. It may be blocked at the AV node. It may be blocked at the bundle branches. As a result, the ventricles use an escape impulse, which is independent of the atrial beat. So this is going to produce a heart rate that's much slower than 75 beats per minute. This condition is life-threatening. It is called ventricular tachycardia, or v-tach for short. You assume that the peaks here are R waves. Okay, those are R wave peaks. Take a moment to count the time with me. I'm just going to use this one here as my 0 time, and I'm going to count to the next R peak. We have 0.2 and 0.4. So the length of my cardiac cycle here is 0.4 seconds. Normally, the length of the cardiac cycle is 0.8 seconds. So we can see the ventricles are beating twice as fast. Twice as fast as normal would be 150 beats per minute. Normal resting heart rate is what? 75 beats per minute. Okay, so unfortunately, this means the SA node is not in control. Some other nervous tissue in the ventricles is likely in control, overriding the SA node and producing this really fast heart rate. How do you know it's fast? Tachycardia, right? That means faster than how many beats per minute? That's 100 beats per minute or faster. And at 150 for this one, we definitely exceed that threshold. This picture is from watchlearnlive.heart.org. They've got a great animation. I encourage you to go and take a look at it. And they show here, in comparison to a normal heart rate, a v-tach heart rate. So there's probably a nerve impulse down here that's bouncing around the walls of these ventricles, causing them to contract much more quickly than the SA node would have the pace set at. So this overrides the SA node, AV node, and something down here is causing a rhythm where we're seeing a really fast heart rate. This problematic condition is called ventricular fibrillation, or v-fib for short. You'll notice there's nothing regular here. In fact, it's very difficult to find any normal sinus rhythm. It is also difficult to time the length of the cardiac cycle because I'm not really sure which one's an R wave. So this is commonly seen in cardiac arrest patients. Ventricular fibrillation, or v-fib, means there's uncoordinated activity in the ventricles. They're not contracting together as a unit. Unfortunately, this can create a condition where clots can be thrown. And again, you can see the irregularness of this heart rhythm down here. Okay, there's no visible P, QRS, or T waves here. So since the heart is unable to eject blood, then we see problems with circulating oxygen out to the cells and tissues of the body. These two that we're going to look at now are considerably less life-threatening: atrial flutter and atrial fibrillation. Atrial flutter results when the atria contract very rapidly, and it produces a sawtooth appearance. Notice the sawtooth appearance here and here, quite routinely seen on this one. That's what characterizes this condition. Left untreated, it can become atrial fibrillation. This one is atrial fibrillation, or AFib for short, and what characterizes this condition on an EKG is its irregular pattern. And what I mean by that is just count the R wave peaks. Let's just use this one as our starting point at 0 time. 0.2, 0.4, approximately 0.6. Let's start over. From there to the next one, 0.2, 0.4, 0.6, 0.8. Let's count to the next heartbeat. 0.2, 0.4, 0.6, 0.8, 1. Let's say that's 1.2 seconds. And then 0.2, 0.4, 0.6. Wow, there's nothing routine here. Each heartbeat does not come at the same time after the last one. So that means there are irregular contractions, and there's an irregular pattern in between those heartbeats. Look at this mess in here. Very difficult to find P waves or even T waves. Okay, so the problem with this is a person may not realize they have it. Because there's these irregular lengths of time between these contractions in the ventricles, there's an opportunity for clots to be thrown to the brain or to other parts of the body. So this increases the risk of stroke. The person who has this may have no symptoms, or they may feel like their heart is butterflying in their chest. They may feel lightheaded. They may have a headache. So there are some symptoms, and people who slip into this can easily return to it time and time again. Something as simple as a sneeze or even diarrhea and vomiting can offset their heart and force it into AFib. Cardioversion using paddles will stop the heart and restart the heart, hopefully in sinus rhythm. And if that doesn't work, there are also medications and some simple ablation surgeries that may be follow-ups for this particular condition. And again, you can see AFib here. This results in irregular signals. Unfortunately, the atria are fibrillating, meaning they're not contracting in a regular routine. All right, and just another view here of the irregularness of AFib, that there's a signal bouncing around the walls of these two atria, causing them to quiver, and the ventricles are not getting a routine signal from them. On the test, you'll simply want to be able to identify what these are and count the length of the cardiac cycle. For those EKGs, it's easy to see.